for next, and I think it's the last. Yes.
Last but never least.
Never least, yes. I would like to have the honor to say hi for our dear Prof. Roberto Oricchia, and he is a professor professor of radiation oncology, University
of Milan.
Of Milan, yes. Print, you know, so, of Milan, Italy. Okay. Thank you very much, and you go for our talk.
Thank you. Good afternoon. So, in the main room, in an hour, we are also to discuss radiation and axilla versus axillary dissection, so maybe the last topic for radiation therapy. So.
I was competing with Hisham for having you with me.
Yeah.
It took us a lot of fun.
Very, very difficult to sustain. I am personally not so convinced. Anyway, so really I appreciate a really huge and very comprehensive overview of all the technical aspects for treating breast cancer and yes, the gynecological cancer. But what I will try to do now is to join the best scenario for technical and also the best scenario for radiobiology and biology of the tumor, because it's only the combination between biology and technique that allow to get a real tailoring of our treatment, especially for the future. We know very well that the role of radiation therapy is important. It's usually recommended in almost all patients after breast conservative surgery, high-risk patients after mastectomy. And today, in the current practice, decision for indicating radiation therapy is still mainly based on patient-related factors, on clinical factors, and on pathological stage. Now we have to move to make an effort in order to get more adaptive radiation therapy to the biology of the tumor, individualizing the treatment according to a wider spectrum of risk categories for local, regional, and distant failures. Just to give an idea of how is important breast cancer for radiation therapy, this is one last report of the ESTRO, the European Society, about the number of patients treated in 2012 in all the Europe, about 400,000 patients, and what is expected is an increase in the next 7-8 years further, 40,000 patients more, with an increase of more than 10% in requests for radiation therapy for breast. It's the same for all the other tumors, as you can see in this slide. As I said, we have tried to overcome the problem of clinical stage, of pathological stage, and to move to the molecular classification of breast cancer. We have main categories that are luminal tumor, luminal A, luminal B, with normally receptor positive. We have HER2 tumors, and we have cancer that are negative for all, and as named, as you know very well, triple negative patient. And normally, the use of molecular subtype is very useful to predict the clinical outcome, including the risk of distal spread of the disease. But what is not so well known is that also molecular subtypes can predict also the local regional risk, of recurrence, and it's very useful in order to tailor radiation therapy. Normally we are not using a true molecular classification, but is based on immunohistochemistry as a sort of surrogate of molecular subtypes, and normally classically divided in 4 different types: luminal A, luminal B, as I said, F2 disease, and basal-like or triple negative disease. You can see in this slide what I said before, well represented, and you can see that the incidence of metastasis is strongly dependent from the molecular subtype, with a lower risk in luminal A patient and a higher risk in basal patients, so very triple negative patients. Also, if you look in the different stage of the tumor, 1, 2, 3, according to the classification, we can find a very important difference if you look in the molecular subtype. And you can see that again, a luminal A tumor is a high probability or higher probability to maintain disease-free survival with respect to patients with HER2 positive or patients with triple negative cancer. If we have the combination, like here, of the very advanced disease and triple negative molecular subtype, you can see that the prognosis is very bad. But as I said, there is a significant association between molecular subtype and also other outcome, like overall survival, distant-free survival already shown, and as I said, local regional recurrence-free survival. This is, as I said, is important. It's not a new this, because we have several studies of at least published 10 years ago or sometimes before, in which has been demonstrated, here you can see study with breast conservative surgery and after mastectomy. You can see that in general, in all the study with different number, with different value, a luminal A tumor has a lower risk of local regional recurrence, and the higher risk, as I presented before, is in patient in HER2 disease and in triple negative disease. The factor of the magnitude of this risk is 2, 3, up to 4 times more with respect to the luminal A tumor. It was also interesting to examine, and all the classic study mentioned thousands of times, is the Danish study that has been also evaluated in order to assess the different effects of post-mastectomy irradiation on not only on survival, the upper part, but in local regional recurrence probability. And you can see that adding post-mastectomy irradiation also in some early cases, you have a significant difference in favor of the adjuvant treatment with respect to no radiation therapy. And the only exception is a patient with receptor, hormonal receptor negative, and HER2 tumor positive. Recently, the Danish trial has been joined with the British Columbia trial. Is a paper of this year, of January of this year, that confirmed that the patient who received post-mastectomy radiation has an overall significant lower incidence of local regional relapse compared to the control, and also for patients with luminal A tumor that should be at lower risk in absolute term, the risk is still low and was further lowered by post-mastectomy irradiation. For this reason, the conclusion of these authors sharing the two trials is there are no indication to omit partial post-mastectomy irradiation in premenopausal high-risk patient, also in case of luminal tumors, and this may be a good indication for practice. In 2012, Lowery made this very interesting meta-analysis, very comprehensive, more than 12,000 patients from 15 studies, patients who received breast-conserving therapy or mastectomy, and with post-operative or not irradiation. Just very fastly, the main conclusion that there was, in general, there is an advantage for no triple-negative patient with respect to triple-negative patients, both for breast-conserving therapy and for mastectomy. And breast-conserving surgery has been also assessed luminal A versus a patient with the overexpression of HER2, and there is an advantage again in favor of luminal A, and the same versus triple-negative with a very high value of significance from the statistical point of view. And between HER2 overexpression and triple-negative, also the risk was higher for triple-negative patients. After mastectomy, the same conclusion, less risk for luminal A versus HER2 overexpressed versus triple-negative. The only difference that has been not observed in mastectomy patients any difference between overexpression and triple-negative. This meta-analysis has been repeated by other authors and it's been published really a few months ago on OncoTarget, that confirmed the same, that luminal A is better than HER2 patient for local regional relapse-free survival, 5 years and 10 years, and also is better with respect to the triple-negative patient. So we can reflect on, we can change our attitude, our schedule for this type of major risk patient. It's interesting to examine the HER2 patient, the period before the use of trastuzumab and the period after the use of trastuzumab. And you can see here on the green line that with the introduction of trastuzumab, we have been able to obtain a very strong decrease in the risk of also isolated local regional with respect to patient treated in the era before trastuzumab. And the same has been considered for any type of local and regional recurrence with a very significant difference with the use or not of the trastuzumab. Trastuzumab changes, that is the first example of real target and biological drug in order that hit a specific molecular subtype, trastuzumab followed in the clinics, and you know that this is also a good example of we can manage so-named new drugs in order to avoid not useful expenses for the health system in general. You know that trastuzumab has been fixed in 1 year of administration, but this is totally arbitrary. And a good idea was to have some independent studies that try to demonstrate if 1 year of administration is the right solution or not. And we have a quite recent meta-analysis of 3 randomized trials, which has been demonstrated that 1 year of trastuzumab is better with respect to the shorter course of trastuzumab, means 6 months, means 9 months. But on the opposite side, the ERA trial that's been updated in 2015 demonstrated that 1 year of trastuzumab was enough, and we don't need to have 2 years of trastuzumab for this type of patients for 2 main reasons. First, you have the same value of disease-free survival, And the second effect in prolonging a 2-year trastuzumab is a strong increase of cardiac events for this type of patients. So it's not safe to continue to prolong. To experience in Korea that confirmed what I said before, here just to say that the only exception in the protection of trastuzumab of any type of recurrence is brain metastasis. Trastuzumab can delay the appearance, sorry, where is the pointer? I don't find anyway. Trastuzumab delay the appearance of brain metastasis, but not avoid the rate, the incidence of metastasis. This is maybe a suggestion for implementing in some selected case brain irradiation. Again, in other patient after neoadjuvant chemotherapy, you can see that on very strong difference in pathological complete response after neoadjuvant